Neoadjuvant chemotherapy, as we know, is a modality that's being used more and more now in the treatment of patients with early-stage breast cancer. We were able to obviously tailor that treatment in several of the subtypes of breast cancer. We tend to use it more in patients with HER2-positive disease and patients with triple-negative disease who have shown us that they're very sensitive to chemotherapy. But with neoadjuvant chemotherapy comes the challenge of delaying surgery until after chemotherapy is completed. And this approach has some unique surgical and even radiotherapy challenges. One of which is, for example, what you do with the assessment of the lymph nodes. There's been some controversy in terms of where you perform the sentinel node, if you do it before or after. But then consensus now is becoming more and more concrete that sentinel node biopsy after neoadjuvant chemotherapy is accurate. It gives us a good idea of what's going on with the nodes, and it allows us to essentially downstage the nodes and potentially treat patients with sentinel node biopsy alone versus a completion X-ray dissection that they may have needed if we had done the biopsy up front. So that is a topic that actually we will receive more data at this year's San Antonio meeting, but certainly the majority now seem to think that sentinel biopsy after neoadjuvant chemotherapy is accurate and actually reflects the status of the axilla.